Next up, one of our experts is Dr. Kelly Andrzejewski, and she is going to be talking about DBS.
Thank you, everyone. So I'm Dr. Kelly Andrzejewski. I'm at the University of Buffalo program, and I'm the medical director of the Deep Brain Stimulation, or DBS, program there. So we're going to talk a little bit about DBS for Parkinson's disease today. So some of the classic motor signs of Parkinson's that Dr. Elmer already talked about is the tremor, the slowness of movement, stiffness, or we call it rigidity. And people often have the difficulty walking, shuffling, gait, freezing of their gait. The main cause of Parkinson's disease is due to the loss of the dopamine brain cells in part of the region that Dr. Elmer mentioned, the nigrostriatal dopamine neurons. So what is DBS for? So deep brain stimulation, or DBS, is used to treat the classic motor signs of Parkinson's. It doesn't treat the non-motor signs, which Dr. Elmer also talked about, but it treats tremor, the rigidity, slowness of movement, as well as dystonia that someone brought up earlier. It can also help with dyskinesias. So Dr. Elmer kind of showed a little bit of an example of, which is the extra involuntary movements that I most often tell my patients, well, if you've seen Michael J. Fox, they've often seen the rocking movements. Sometimes those can be quite significant, other times they're very subtle. And as I said, though, typically DBS does not help with the non-motor symptoms. So when patients come to me and they want their constipation to be improved or their gastroparesis, in most cases, patients don't notice a change in that. Sometimes people come to me and feel that there's a change, but that's not why we do DBS. So what is DBS? So DBS, or deep brain stimulation, essentially involves us putting a wire into the brain that one of my neurosurgeons does, and we deliver a small amount of electricity into one of two different areas of the brain. The wire is connected through what they call like an extension wire down into a battery that's placed right underneath the collarbone, underneath the skin, much like a pacemaker, if you know someone that has a pacemaker. DBS is not for everyone, but for some people it can be very beneficial. So these are the kind of some of the visual components. So you can see the batteries there, as well as kind of the tip of the wire. Like I said, people can have either one or two leads, so sometimes they have DBS on both sides. Sometimes they just have it on one side if they really only have symptoms on the one side. Your brain, actually, the right side of your brain controls the left side of your body, and the left side of your body actually controls the right side of, the left side of your brain controls the right side of your body. So it's kind of counterintuitive sometimes, but very, very interesting. So what are the kind of indications for DBS surgery? So as Dr. Elmer talked about what we call motor fluctuations, which is the frequent up and down and up and down. Over time, as you have less brain dopamine cells, because they kind of die off during, as the Parkinson's progresses, you need more dopamine, which is produced from the levodopa that you take, or your carbidopa-levodopa. You need more of it over time. So people often notice as their meds kick in and wear off, their symptoms get a little bit better, and then they get worse again. And they get better and they get worse. So DBS helps smooth out so you have less of those hills and valleys. Some people's tremor that they have with Parkinson's can be quite intense. Not everyone has tremor, but for some of those that do, it can be pretty disabling. Some people find that the tremor actually gets better with carbidopa-levodopa. Other times they don't notice much of a change. So one thing I always tell my patients is just because your tremor didn't get better or didn't completely resolve with the carbidopa-levodopa does not mean you're not a DBS candidate. So tremor can be very effectively controlled with deep brain stimulation and can be quite life-altering, meaning in a good way. Other things that we talked about was dyskinesias. So DBS can be very effective to treat dyskinesias. We don't have a whole lot of tools in our toolbox to help with dyskinesias. One of the main medications is amantadine that sometimes can help, or just the doctor doing their best to try to optimize your meds so that you have less of those ups and downs. Typically, dyskinesias occur when their medication, an individual's levodopa medication is peaking. But either way, DBS can be very effective at controlling dyskinesias. So this is an example
Both hands out like this.
video
Spread
from
your
one of our
fingers
DBS companies of an individual with Parkinson's
Now,
disease
put
with
your
his
hands like this.
medications on board, but no DBS yet. And you can see his tremor is more prominent on one side over the other.
Now with both hands, go like this.
And you can kind of see
Up to the ceiling. Now go as
he's
quick
got a
as
little
you
bit
can.
of slowness of movements, but he does have his medications on board here. But then you see his tremor kind of break through after a few seconds.
Now let them go. Cross your arms and stand up.
And then this is where
Put your arms
he
down
crosses
now.
his
Walk straight
arms.
back.
And you can see now he's trying to take a step, and he's got that initial kind of shuffling like many of you may have. He's also in a small room, which makes it a lot harder for him to walk. This is kind of, but you can see he's still tremoring more on the one side and shuffling, got a little bit faster. But now we will see him after DBS. So
Hands straight out like
he
that.
looks
Spread your
pretty
fingers wide
still.
apart. Hold them there.
puts his arms out in front of him,
Bend
and you
your
don't really
elbows.
see that
Point your
tremor kind of
fingers
come
like
back
this, like
out.
this. Look at your fingertips. Get them as close together as you can without letting them touch. Very good. And with both hands, go like this, back and forth, as fast as
So you
can
can
go.
see he actually is moving a little bit better there when he's turning his arms back and forth.
Cross your arms and stand. Again, let your arms down and walk back and forth, several paces now.
So you can see he still has a little bit of
Just walk
shuffling.
back and forth.
The
Just keep
DBS
going.
doesn't completely take away all of the Parkinson's symptoms, and people still need their Parkinson's medications after DBS. I always try to stress that to patients, that DBS is not a reason to stop your medications or try to go off your medications yourself. You need to listen to the doctor and work with them. Sometimes we can reduce people's medications, and sometimes we can't. And the goal of DBS surgery is not to decrease or get off your Parkinson's medications. It's to have a better quality of life and less tremor, less dyskinesias. Depending on the brain target your doctor chooses, there's two different brain targets we use in Parkinson's. And depending on the brain target, one is more apt to be able to reduce medications, the other one isn't. But that's a discussion between you and your doctor. And the goal of decreasing your Parkinson's meds should never be the goal of DBS surgery. So who qualifies for DBS surgery? Or excuse me, who does not qualify for people with DBS surgery? So some people have kind of what we call atypical forms or kind of variants or what we call Parkinson's-like type disorders that often don't respond as well to medications like carbidopa, levodopa. So those people aren't good candidates for DBS. People with dementia also. Oftentimes, in some cases, we always do thinking and memory or cognition testing before we do DBS in a Parkinson's patient, because if people have, not a lot of reserve to begin with, DBS sometimes can cause a little bit more difficulty with memory and thinking. Not in most people, but it's kind of a red flag that if you're having a lot of trouble, that maybe that's not the best thing to do. Sometimes, too, people, if they have certain medical conditions, they may just not be a candidate. It might be too risky to do brain surgery in them. And then sometimes even if people have significant disability, even in the on state, they're falling tons and tons and tons, putting hardware in them, if you're falling continuously all the time, might be a little dangerous because you could knock that hardware and it might not like that. So if you come and see, whether it's me or in another city, someone that does deep brain stimulation, after you've seen, have the wires placed and the battery placed, you'll come in for what we call the initial programming here. So essentially each DBS wire has 4 different contacts on it that can deliver electricity. So in your first visit, to turn your stimulator on, we actually check benefit to help with your Parkinson's symptoms with each contact, and then pick the best one that we think will help control your symptoms. Mind you, there's thousands of combinations that we can create for your DBS setting. So the first day we turn it on is not usually the first setting that maybe is the best setting. It takes time, and you have to work with your doctors and your nurses that are doing the programming. to try to find the best setting that we can to help you. So risks of surgery is that some people can have worsening of their Parkinson's symptoms compared to baseline. It's not a lot, but it can happen. There's a risk of hemorrhage or brain bleeding that potentially could lead to paralysis or death. The risk is very low, but it's still there. Like I said, sometimes people have the risk of having worsening of cognition, which is why we do the thinking and memory testing prior to doing DBS surgery in a Parkinson's patients. There's also about a 6% risk of infection or breakage of the hardware somewhere in between the brain and the battery. It's unlikely, but it can happen. As we've gone on in the years, the DBS manufacturing hardware and that has become a little bit better. So I think we're in a pretty good spot today. A couple other risks are there's about less than a 1% chance of death, seizure, or suicide. But we have to quote these to our patients because any kind of surgical procedure is not without risk, and it is an elective surgery. However, as you can see here, what people are able to do. So this is kind of a little bit of small, but essentially people have much better quality of life. They're able to do more activities of daily living, as we say, eating and dressing independently much easier, sometimes after DBS surgery. And this kind of shows you the change in what we describe as on time versus off time. So you can see in people that have DBS and where it says BMT, meaning best medical therapy or management with medications, that 6 months after DBS compared to people that don't have DBS, they have more benefit, increased on time, meaning that their medications are working well without the dyskinesias, which are the involuntary kind of rocking movements. So this is our team here in Buffalo. So anyone that's going to get currently right now DBS in Buffalo will see me first. I jokingly say the gatekeeper of DBS in Buffalo. If I feel that you were a candidate here in Buffalo, then you would meet with one of our neurosurgeons and we'd kind of move on from there. And that's something that if you actually come to one of our what we call DBS seminars, which are a free seminar for you to attend, the next one is on July 9th at 4 o'clock. We're located in Orchard Park on Big Tree Road. I'm actually within the UB neurosurgery office, so I see patients in Orchard Park that are primarily the DBS patients, and then I also see patients in Williamsville. But you can RSVP if you're interested to one of our 2 DBS nurses, Pat Weigel, and her number is up there. I believe there's also should be cards out in kind of the little foyer hallway area that actually have the number and everything on it. So I look forward to hopefully meeting some of you in the future, and I hope you have a good day.